complete coverage of our grafts, increasing our predictability, and we are not compromising so much the mucogingival junction as if we were to use just a coronally dense flap. The other good thing about the technique is that we can deal much better than a coronally dense flap with very uneven recessions. So may I have a recession of 2 millimeters just next to a 5 millimeters, then a 3 millimeters, and that handling that unevenness among recessions gets to be a little bit more difficult. Not with it laterally, with the last cuff technique. So to finish my presentation, perhaps you were wondering how it's going to deal with high frenulum attachments or high muscle attachments. This is how we always do it now. We do not do external frenectomies. Once I open the flap, I'll show you what I do. This is a very, very severe, very complex case. Multiple recessions. We're going to be treating from canine to canine again. So this is a mixed combination, oblique incisions with horizontal incisions. And you can see that in the middle, that white thing, that's the fibrous attachment of a frenulum. Once I've done the submucosal and the periosteal release, I grab that tissue with a pair of cotton pliers, and very carefully I have to remark that, with an electrosurgery, making sure the intensity is not that much that I will produce lots of necrosis, I go ahead and remove the tissue. And I remove the fibrous tissue, the frenulum, and sometimes on the sides I will remove the most corollan insertion of the muscle, something that's called a myectomy. Very safely, almost no bleeding at all in these procedures. And you can see how the bed is completely prepared. Go ahead. And you can see now that there's ample relaxation, freeing of that flap. So relaxed is that flap that allowed us to close it laterally, not one recession, not two, but 5 recessions in the same area. I went ahead, harvested again with a double blade, large graft from the palate, sutured it in place, and then covered all the graft completely with our double moved flap. And that is the 1 year post-op of this case. So, we've talked about flap mobilization and how to perform it. And perhaps how to perform it is not the most significant thing. I just showed you the way I do it. Ilam just showed you the way she does it. If you were at Martina Stefanini's lecture this morning, you saw the same technique with a knife. It doesn't really matter how you do it. What it really matters is what you do. What you do here is detach, again, the gingiva, the mucosa, from the underlying muscles. Hopefully without causing perforations or excessive bleeding. If you think all that you've seen before, cutting those muscles, pulling those muscles, tearing the fibers apart, even burning the fibers is too traumatic, I urge you, think again. What it is traumatic is tension to the flap. And releasing that tension is being a careful surgeon. So, ladies and gentlemen, please remember, free those tissues. And I'm sure many of you do master these techniques. But for the ones of you who don't still, when you do master the releasing techniques, when you feel very comfortable playing and working around those planes of dissection, you will discover a much better version of the surgeon you are today. Thank you very much.
Presentation.
Thank you. Thank you for the presentations. We are going to continue with the discussion, I would like to show you this clinical case with multiple recessions. So my first question is for the Professor Christgau. Let's consider that this patient has flat palatal anatomy and you have to treat multiple recessions. How do you approach graft harvesting in these situations?
Okay, it depends how flat the palate is and what height of tissue I need. But of course, for this situation in a flat palate, it would be easier to take an deepitalized gingival graft to avoid any major violation of the artery or of the nerve, of course. Yeah, and perhaps I would treat it with a tunnel technique and using a deepitalized tissue, similar like I showed in my first case.
Yeah. Thank you. Also, we have some questions from the audience. The first question is for Dr. Mounssif. Is the Gauss technique suitable for the other areas in the mouth to prevent the need of deep dissection?
Yes, it can be used, but usually we do not perform it in other situation, other anatomical situation, because it's safe, the deep dissection. Even if we think, for instance, to the infraorbital nerve, actually is very, very high in terms of emergence, so the deep dissection, it is very limited in terms of quantity, and it's easy to be performed without any type of, let's say, complications in other sides of the mouth, so we usually perform it.
So we can conclude that the main indication...
Yeah, the main indication is for the mental nerve to avoid any type of injury.
And we have another question. The use of modified coronal advanced tunnel technique in these anatomical areas have less risk than coronally advanced flap?
The tunnel, the modified tunnel.
The modified.
She's referring, I think, to the modified coronally advanced tunnel.
Advanced tunnel.
I don't think so, because you perform a technique that is completely blind, so you are not really see what you are doing. So it's not. It has more risks, and I think also you are not able to advance so very well, because you are always have to care about the emergence of the nerve, the location. So you work very coronally with respect to its position. So I don't think that is
indication.
Yeah.
The next question is for Professor Carranza. How much through mucogingival line is necessary to touch the flap?
How much beyond the mucogingival junction? Okay, usually, let's talk about both planes of dissection. I usually go around a centimeter beyond the mucogingival junction on the periosteal plane, unless there's some anatomical limitations. And Dr. Mounssif just talked about you cannot do that safely around the area of the mental nerve. But usually about a centimeter is quite enough. That will give me lots of visibility, access to the place, and allow sufficient tissue down there so I can anchor my sutures afterwards. And then as far as the submucosal release is concerned, it's usually about the same distance, but there's not a defined measurement. Well, I'll just go ahead and start releasing the flap until I get sufficient mobility to put the flap where it will have to go in a passive way. So probably a coronally advanced flap will not need such an aggressive release. Perhaps a last scarf will require more than that, but it's usually around a centimeter and sometimes even 2 centimeters.
Also, in cases where there is no keratinized tissue, how do you modify the surgical technique?
There's no modification, actually. It's the same surgical technique. When you laterally stretch, I guess we're talking about the laterally stretched flap. When you laterally stretch the flap, usually on the sides of that recession, there's keratinized tissue. So you immediately gain keratinized tissue on the recession itself.
Thank you. I have a question for all of you. What do you think about the most critical factor that influence the endpoint that is complete root coverage?
Can I answer that question? A root coverage is such a technically sensitive procedure that it has to be inevitably a change of perfections. I mean, the change will break on its weakest link. So there's no significant. I learn how to detach the flaps, then everything is fine. No, I mean everything has to be perfect from the incision, from the diagnosis to the suturing.
Absolutely.
Yeah.
It's a complex procedure.
Yeah.
Depends on so
Totally
many
agree.
different factors.
It's not for the surgeon in a hurry, definitely.
Not at all. But it's also not a life-threatening disease.
Yeah.
I totally agree with them because we can put together several factors, but each step counts and for the final outcome. So
Yeah, for sure. About the protection of the palate, how do you perform, or how, if you prefer use vacuums, sutures, dressings, how do you manage the postoperative?
As I showed, the most important thing for me is to have a protection plate ready to avoid any major bleeding and to protect the wound, because the protection plate keeps the tongue away. It holds a space for the blood coagulum, which is a basis for perfect healing. And if you have major problems with bleeding, you can use this kind of resorbable strip of oxidized cellulose, or you can take an xenogenic collagen matrix. You can apply, it's described, you can use PRP or something like this to increase the wound healing. But in my experience, I left the collagen matrix and all these things. I apply simply this strip of oxidized cellulose and leave the same to the body, the rest to the body, and it's the best thing, in my opinion.
I agree. We have more questions for Professor Carranza. Do we need to make additional anchor sutures? Additional anchor sutures in coronally advanced flap or to fix the connective tissue graft?
If we do need to do them?
Yeah.
Well, I'm not sure I'm understanding correctly the question. You need to make sure that your graft is first intimately adapted to its bed, because it will survive. It requires intimate adaptation of those tissues to survive, especially in the first 72 hours. And then you need to make sure it won't move. So you need to suture it, anchor it as needed. And sometimes, especially in the lower anterior, where the architecture of the bone is sometimes very irregular with prominent roots and very deep interdental spaces, usually thanks to the orthodontists, then the apical coronal suturing becomes actually almost a requirement, a necessity.
Thank you. And last question for Professor Christgau. How do you manage bleedings from the palatine artery?
Okay, so first and the most important thing is to avoid it.
to avoid.
To avoid it and not to to drive the risk too high. In my whole professional life, I had only one real cut of the artery. It was in a very flat, toothless palate. But if it happens, you have to take a suture and have to stitch around the artery and try to constrict the vessel, of course. And the other thing, again, is you can apply anesthesia with adrenaline. And the next thing is, of course, the protection plate. This is the most important. Then you can put your thumb on it and press it for 5 minutes or more.
Yeah,
and
great.
it tells the same as the patient if he experiences bleeding at home. he only should take his thumb and press